Perinatal asphyxia. What is perinatal asphyxia? It is an insult to the fetus or newborn infant due to lack of oxygen, which is called hypoxia, and or lack of perfusion to various organs, which is called ischemia. It will be manifested or demonstrated as difficulty in establishment of spontaneous respiration, which will be evident by delayed cry after birth. At least after 1 minute, the baby will cry. What are the causes of perinatal asphyxia or birth asphyxia? They can be divided into two groups. One is before birth or fetal hypoxia, and another is after birth. Before birth or fetal hypoxia occurs due to inadequate oxygenation of maternal blood because of hypoventilation, which occurs during anesthesia, cyanotic heart disease, pneumonia, or respiratory failure. When the mother has hypotension, the maternal blood pressure is low, which can cause fetal hypoxia. When excessive oxytocin is applied, then there is uterine tetany or inadequate relaxation of the uterus, which can cause fetal hypoxia. Then the placenta can be prematurely separated. Then the umbilical cord can be knotted, which results in impairment of circulation of blood to the fetus, and again there can be placental insufficiency in toxemia or post-maturity. They all can cause fetal hypoxia. After birth, hypoxia can occur due to severe anemia in case of hemorrhage or hemolytic disease. Hypoxia can occur due to shock in case of severe infection or massive blood loss or intracranial or adrenal hemorrhage. The newborn baby can fail to breathe adequately because of trauma, narcosis or drugs, or due to cerebral defect. There may be failure of oxygenation due to pulmonary or heart disease, and unscientific delivery can also cause hypoxia or asphyxia. How can we manage the case of perinatal asphyxia? We can do immediate resuscitation by keeping the baby warm, by warm environment, or immediate drying, and wrapping with dry warm towel. And we should keep the baby with mother's skin to skin contact if possible. We should try to open and maintain the airway by keeping neutral airway position, which is neither overextension nor hyperflexion of the neck. Then we should lift the chin and thrust the jaw, and we should place a towel roll of 2 cm under the shoulder. We should clean the airway by gentle suction, etc. We should support breathing by stimulating the baby. For example, rubbing the back gently, or slapping, or flicking the sole of the foot. We should give positive pressure ventilation using bag and mask with or without endotracheal tube. Mechanical ventilation can also be done. We have to maintain circulation and oxygenation by chest compression and coordinated positive pressure ventilation. After resuscitation, we have to do post-resuscitation management. We can do that by maintaining the body temperature. We can support respiration by supplement of oxygen 2 liter per minute by nasal cannula or by head box 5 to 6 liter per minute. We have to do fluid management by providing IV fluid and electrolyte to maintain adequate hydration, electrolytes and glucose homeostasis. We have to measure the total body allowance, and the fluid has to be restricted 10 to 20% of total body allowance. Other managements are we should regularly monitor bedside for respiratory status. Example, if cyanosis is present or respiratory rate, rhythm and pattern are normal, then circulatory status should be monitored like heart rate, blood pressure, CRT or cardiac resynchronization therapy. We have to check capillary glucose status. We should also check arterial blood glucose analysis. If signs of shock, for example, CRT is more than 3 seconds, low pulse volume and low blood pressure is present, then we have to infuse normal saline 10 milligram per kg over 30 minutes and give dopamine or dobutamine 5 to 10 microgram per kg per minute. If convulsion is present, we have to provide anticonvulsant. If sepsis is present, we have to give parenteral antibiotics.